Good evening, everybody. Thank you very much for coming in to join us, coming in outside of the lovely Geneva sunshine into this dark little room, but we hope we can put on a nice show for you tonight. I am just off the plane from Australia yesterday afternoon, so my ability to string coherent sentences together still hasn't quite returned, so apologies for any stumbles or slip-ups. My name is Nick Chapman. I'm the CEO of Policy Cures Research, and it's my pleasure to welcome you here today to our session on the impact of investing in global health R&D. This event marks the culmination of a couple of years of dedicated work by Policy Cures Research and our wonderful project partners. So I'd like to start by expressing my heartfelt thanks and our heartfelt thanks to those partners, to Anthology, the magic makers behind the animation and the storytelling that you'll see in our event tonight, and through the impact report on our website, to Avenir Health, our health impact modelling partners, to the African Population Health Research Centre, to the Centre for Global Development, and to the Stanford Innovative Medicines Accelerator. I'd also like to acknowledge and express my gratitude to my wonderful team at Policy Cures Research, whose dedication and commitment to this project over the last 2 and a bit years has been above and beyond often. A special thank you to our expert advisory group, some of whom are in the audience tonight and who have provided invaluable counsel over the last couple of years, and to the generous funders of the project, the Gates Foundation, Open Philanthropy, and Welcome. I'd also like to thank in advance our esteemed panel for tonight, whom you'll get to hear from in a moment after Andrew and Vanessa's keynote address. We embarked on this project to answer a fundamental question. Are we doing the right thing by investing in global health R&D? As members of the global health R&D community, our starting point for the answer to that question was yes, but we wanted to evaluate that bias. Through this project, answer the question in a way that interrogated the foundations, validated the findings, and quantified the impact. Now, this beguilingly and apparently simple question soon led us to interrogate the complexities of measuring impact. How, in fact, do we define and measure impact? What types of impact matter to different stakeholders? What evidence exists already? And what do we need to generate? We debated and refined hundreds of indicators to create a global health R&D measurement framework, impact measurement framework, pardon me, that has already taken life beyond the confines of this project and that we hope will be a lasting tool that serves those in this ecosystem well into the future. We also collected extensive foundational data on funding landscapes, on the wealth of products developed over the last couple of decades, on the innovative technologies in the R&D pipeline, and on current priorities in neglected disease R&D. This data underpins our analysis, leading to the development of the comprehensive report we're launching tonight, but also stands as a resource in its own right to help inform and guide the global health R&D community. Now, I won't steal Andrew and Vanessa's thunder by revealing the findings right now, but I am happy to confirm that the health, economic, and societal impacts identified in our analysis make a compelling case for investing in R&D for global health. The return on investment is impressive, benefiting both affected communities and society at large, with broader knock-on benefits. I'm inspired by the potential our findings represent, but recognise that there is much work ahead. Indeed, most of the estimated impact that we project will unfold in the next 15 years, and thus is contingent on a global ecosystem capable of scaling health innovations and continuing to advance the pipeline of breakthrough technologies that we currently have. It's our hope that this report and today's session lay the foundation for critical policymaking and advocacy efforts, as well as future-oriented discussions around how we can collectively shape the future of investing in global health R&D to accelerate progress and ensure access to the life-saving health innovations that the world needs. So we're about to do a deep dive into the findings of the impact of investing in global health R&D, which will be followed by a high-level panel discussion addressing the implications of these findings and implications of these findings for the future of the global health R&D agenda. So without further ado, very pleased to hand over to Andrew Tuttle, our Chief Strategy Officer, and Vanessa Candeias, Senior Analyst, who together have co-led the Evidence for Impact project over the last couple of years, and who will walk you through the findings of this breakthrough report. Thank you.
Research and development into new solutions to tackle infectious diseases in low and middle income countries has historically been underfunded, under-resourced, and championed by a small but mighty community of advocacy and research organizations. But over the last 20 years, deaths from poverty-related neglected diseases have dropped by 30%, from 8.9 million a year to 6.1 million a year in 2019. This is thanks to many things, including some seismic shifts during this period, which heralded a rise in funding for global health research and development. Between 1994 and 2022, an estimated $97.9 billion has been invested in neglected disease R&D for basic research, drugs, diagnostics, vaccines, biologics, microbicides, and vector control products. Now, while this may sound like a huge sum, it pales in comparison to many other areas of pharmaceutical R&D and R&D in general. In a single year, neglected disease R&D has averaged around $4 billion, compared to cancer R&D at $50 billion and $89 billion by the top 11 biopharma companies in a single year. In 2022 alone, the spend across all R&D was nearly $2.5 trillion. Despite its modest funding levels, though, the neglected diseases sector has punched above its weight for more than 2 decades and has delivered an impactful portfolio of products and a rich pipeline that promises to deliver many more life-changing innovations in the future.
Since 1999, 183 products have come to market to tackle poverty-related neglected diseases, including some game changers such as the first ever malaria vaccines and the direct-acting antivirals, which have made hepatitis C curable. We also now have the most robust pipeline we have ever seen for neglected diseases, with 752 active candidates. We estimate that between now and 2040, 182 of these candidates will emerge as approved new products. We have made significant progress over the last 20 years in fighting these diseases, and there is a promising horizon of new innovations if we don't take our foot off the gas. So, what is the impact of this investment, and why should we double down on our efforts now? We took a selection of approved and expected to launch products, and we modeled the incremental health, economic, and societal impact of these innovations have had already and will have in the future. Launched products have already saved 8 million lives across the globe. And with the continued scale up and introduction of additional health innovations, more than 32 million additional lives will be saved between now and 2040. That is a total of 40.7 million lives. Now, if we measure disability adjusted life years, or DALYs averted, we can understand not just the number of lives saved, but the years of life saved. This shows us the improvements in health that these products have helped to deliver. And when we reframe the health impact in terms of DALYs, we see that those 40.7 million lives saved equate to a staggering number of 2.83 billion DALYs averted.
Now let's look at these health outcomes in economic terms. What's the societal return on the investment in global health R&D? The first thing we can do is to estimate the value of a DALY. While there are many ways to do this, we've used a preference-based approach that takes the dollar figure for a value of a statistical life and adjusts for income elasticity and the willingness to pay for mortality risk reduction. This results in a value of just under $20,000 per DALY averted. After multiplying the figure by the number of DALYs averted, we arrive at a staggering $49.4 trillion in value of improved health and longer lives. To put that in context, that's almost a third of the entire US household wealth at the end of last year. But this is not the full story. People whose lives are saved or improved through better health make important contributions to society and help boost the economy. We very conservatively estimate these benefits at an additional $270 billion. Conducting R&D delivers real benefits to the country that performs it, even if they don't benefit at all from any of the products that are created. Building an industry that can carry out decades worth of biomedical R&D delivers jobs and benefits both inside and outside the sector via a multiplier effect. It also helps build the sector's long-term capacity to carry out R&D in other related fields. So the same industry that produces a vaccine for TB or malaria might one day accelerate the development of commercial vaccines for COVID or hepatitis. When we include this additional value, our overall estimate climbs by another $262 billion. Now let's account for the cost of the health system required to deliver these innovations. Factoring the price of the products themselves, the costs of moving them through supply chains to pharmacies, clinics, and hospitals, and the service delivery costs of administering them by healthcare workers, we must subtract from all of this economic benefit an estimated total cost of $213 billion. This leaves us with a net economic benefit of $49.7 trillion. Now we're finally in a position to compare how much we've spent to the value of everything that society got back. The investment since 1994 to date in global health R&D and the estimated future funding necessary to complete the products already in the pipeline totals around $122.7 billion. If we take the estimated net benefit of $49.7 trillion and we divide this by the total investment of $122.7 billion, we can see that every dollar spent on neglected disease R&D and developing life-saving products returns $405 in wider societal and economic gain. This return to society is on its own huge. And when we think about all of the knock-on benefits of investing in global health R&D, including empowerment of neglected communities, progress towards disease elimination, the promotion of gender and social equity, and the knowledge sharing and research foundations that spill over into other areas of R&D, especially COVID, this figure likely vastly underestimates the full return that we've gained as a society already.
So it's a big success story, but that doesn't mean we can rest on our laurels. We need to take action now to realize the full range of benefits we've described. Over 70% of the benefits from the past 20 years of investment will occur between now and 2040. So if this benefit is to be realized, there needs to be sufficient ongoing investment in R&D to deliver the products that have not yet been approved, but which are expected based on the current state of the pipeline. We also need to strengthen our healthcare systems and have the political commitment to rolling out and scaling up the health innovation that our model assumes. So, as a community, we need to pursue collaborative mechanisms for investment and financing of global health R&D. We need to focus on portfolio investment for greatest returns. We need to optimize efficiency of the regulatory and scale-up pathways to reduce time from product approval to scale up. We need to recognize the strategic value of investing in impact assessment. And of course, we need to strengthen collaboration between R&D and access.
Global health product innovations help transform the pace, reach, and scale of saving lives, eliminating disease, and growing economies. With such a clear case for ongoing investment, let's focus the next 20 years on shaping a more efficient, equitable system. Thank you very much. It's my pleasure now to introduce and invite our panelists to take the stage. The moderator for today's discussion is Dr. Jay Iyer, Chief Executive Officer of the Access to Medicine Foundation. Also joining us is Dr. Luis Pizarro, Executive Director at DNDi, Dr. Thomas Breuer, Chief Global Health Officer at GSK, Ms. Andrea Lucard, Chief Officer, Corporate Strategy and Affairs for the Medicines for Malaria Venture. I'm not sure if Agnes made it today. Is Dr. Agnes Benaguaja with us? That's all right. Maybe she'll join us. And Ms. Cynthia Mwase, Director, Africa Health at the Bill and Melinda Gates Foundation.
Thank you, Andrew, for this. And what amazing numbers and figures. I think the case is so clear for investment in research and development. So let's spend some time today in today's panel to talk through what does this mean for the path ahead? What are some do's, don'ts, and areas that we need to focus on? So let's start off with Luis. Luis, DNDi has celebrated its 20th anniversary last year. And since its creation has been responsible for 30 treatments for some of the diseases that Vanessa and Andrew just spoke about, saving millions of lives. So can you share your views on how important are impact measurements that you've seen so far for some of the NTDs, especially when you have an importance in looking at equity-centric access itself? And do you want to share some other examples that have not been covered in the numbers just brought in by PulseSecure's research?
Thank you. Thank you very much. I mean, first of all, I'm very pleased to be here because you said we celebrated 20th anniversary, and it was exactly in this place. It was less beautiful than the one I saw here, and James from the communication will not like I'm saying this, because that was amazing. I have to say, it's not only the content that it's absolutely powerful and very, very robust, but also is the way we tell the story. And doing this, you are contributing a lot for that. We're discussing this morning about the amazing report you have brought here, that of course of advocacy in terms of education, of our partners. But we said that if we think, for instance, Professor Schiffman from Johns Hopkins published some years ago in The Lancet a nice paper talking about the three main drivers of the global health agenda. And he said that, of course, the first one is the evidence-based. And here we have a very good example of how evidence-based can contribute to put this in the top of the agenda. But he talked also about two other things, the sense of emergency and the moral, the values we want to put in place. And those are probably the one I would like to insist. When we think about emergency, pandemic preparedness, etc., there is an important role to address neglected tropical diseases on this, because we know that, for instance, dengue is today an emergency, that outbreaks are going all around the world. And more than an evidence-based situation, it's something we need to prevent really as a public health emergency. But it's not only an emergency in the classical way, it's an emergency also in the sense that there is the possibility today to eliminate some of those diseases. And the elimination of those diseases is priceless, I would say. And it's something, it's really here. If you take sleep and sickness, 20 years ago, we didn't have really a treatment. The only one was awful for patients, killing 1 in 20. And we have shown that working together with the pharma sector, with ministers of health, with the research, it's possible to have now a drug called acoziborole that can cure patients just with one take. So we have everything, the test and the treatment to eliminate a disease like sleep and sickness, and we hope it's going to be the same for leishmaniasis. And there is, I guess, a public health emergency to go there for elimination. And the third one I mentioned was the values, the moral. And here is what you said, equity. we cannot talk about universal health coverage if we're not covering everybody. If we start doing a ranking, prioritizing patients and saying we're going just to address the ones that are in the top, and we're not addressing everybody, especially the most vulnerable population, it's impossible to talk about universal health coverage. And we think that for this equitable approach we're defending in global health, it's absolutely key also to consider that. And I'm very pleased that our colleagues from PolicyCure have been mentioning this, that the numbers, the economical numbers you've shown, underestimate, I would say, the value of working on entities.
Great. And can you just add on a bit on what do you see are some of the major changes and evolutions in the policy landscape for research and development that is driving investment into neglected tropical diseases, and what does that mean for the next 10 years coming ahead?
I would say, I think the model we have been promoting at the NDI, it's really a collaborative model, a platform model, and we're not the only one. Let's be clear. Of course, I'm very, very pleased, and I love the work our teams are doing to bring everybody around the table and build what we could call the common goods. It's a scientific knowledge, open science, the best science, but in an open way, shared by everybody. But let's be clear, a lot of colleagues working in product development partnerships, as MMV here, FINE and others, are bringing this approach of a corporate model. Not an easy one, because there is sometimes, skepticism from the community saying that there is only one model of research and development to succeed. And I think we need to continue telling the right story on how we are able to bring private companies. GSK, for instance, is working with us in a lot of leishmaniasis projects, for instance, and public sector in countries, because they are the one who are best interested, but also, all around the world. So this is an important one. And the second maybe is that here we're addressing probably the classical ODA donors from what people call the global north. But we know that more and more countries like India, like Brazil, the BRICS, emerging economies, they want to tackle those elements because it's their population who is suffering from this. So I was also discussing with colleagues from PolicyCure is how we succeed to take those numbers in order to influence public policies also in endemic countries, to succeed. So I just want to insist on this collective effort we need to do all together.
Right. And the cases are extremely compelling, enough to also engage, I hope, the industry more and more in infectious disease and priority disease R&D itself. GlaxoSmithKline has been actually topping our Access to Medicine Index rankings for a number of years because of its high investment, highest in the industry in priority diseases itself. So Thomas, the numbers presented today are an extremely compelling case for investment in research and development itself. So what is GSK's investment in global health R&D? Can you tell us a bit more about how do you prioritize these investments within the company itself? And as products come to the market, there's also that downstream access component of it. How do you make sure that you're ensuring that access by embedding it early into your system?
Okay, thank you for the question. Before answering, I just want to congratulate PolicyCure also for the presentation, presenting it in a very humble way and let the numbers speak for themselves. So it was quite impressive. So GSK has a long-term commitment to global health, and we are committed to change the trajectory of high-burden diseases in lower-income countries with a focus on prevention and treatment of infectious diseases. Everything I'm saying now has nothing to do with the commercial part of GSK, but just with the global health part of GSK. So in global health, we have two R&D units, one exclusively focused on development of new medicines for global health, new TB medicines, to new malaria medicines, new NTD medicines working with you. And we have a similar unit for vaccines, exclusively focused on vaccines for the developing world, typhoid, paratyphoid, Shigella. We're also working on a second generation malaria vaccine in the early stages. So, and GSK 2 years ago committed £1 billion over the next 10 years to drive this development. We also get funding from external, but the lion's share is coming from GSK. And I just was in another meeting where I said that I'm a cost center, so I'm not a part of the P&L of GSK. This is an investment GSK puts out there, and the way it's organized, the global health team, the two R&D organizations. Then we have an access unit where we provide selected products to the developing world, donation products like albendazole, the 1.2 billion doses with Gavi funding, which go to UNICEF, the vaccine. And then we have capacity and capability building activities. So then your second question was on access. You might also know that the HIV arm of GSK, it's a joint venture with Pfizer, has a specific model where we give voluntarily licenses to generic companies. So we keep the market, the high income market, and make the money back. We have invested in R&D and plus profit, obviously, but at the same time or soon after, giving voluntarily licenses to generics. That's one aspect. Then coming back to the products for global health, you have to distinguish between products which we sell in high-income countries and low-income countries. And there it's essentially economics of scale. When you take our pneumococcal vaccine, roughly 70% of the volume every year go to Gavi and 30% go to higher income countries. So with the 30%, we make all the profits so that we can afford to have the 70% which goes to Gavi. And then, as I said, we also develop in our global health R&D units drugs and vaccines which will never make any profit. And there the model is different. We develop the products until proof of principle and then try to find another company which takes over the baton, runs the phase 3 and get the license. And just to prove that that actually works, we developed a typhoid vaccine which went to BioE. Our malaria vaccine, which is currently supplied by GSK, in a few years will be supplied, and the license holder will be a company called Bharat. We are currently in the process of tech transferring it. And the TB vaccine, which we developed up to proof of concept, is now taken over by the Gates Medical Research Institute, which is funded by the Gates Foundation and welcome to drive to the phase 3, and they will find a future manufacturer for this vaccine as well. I think I captured your two questions.
Yeah, no, thanks for that. So Cynthia, what do you think that these impact numbers that have been presented today, what does that mean from a country and regional perspective, particularly when it comes to access for delivery for patients most in need? What do these numbers actually mean for access?
Probably I should answer that question by starting with a question which wasn't asked to me, but I immediately thought when you asked the first question, what numbers I think we could have also included in the report. I was thinking about the cost of not spending now is also a key number. And in a meeting a few years ago with the ministers of finance for countries, as they thought about how to allocate budget to ministries of health, that was a profound number. For some reason, ministers of finance have heard the life saved numbers so many times that somehow it wasn't having the impact that we've wanted them to have. But when we put up the numbers of what the cost will be if you want to spend 5 years from now rather than spending now, that made everybody sit up in the room. So that has stayed with me for quite some time. So I think as we do research, that's one important thing. The second one for me is the hard space of nowcasting versus forecasting. When we do research, usually we take data from things that have happened in the past or happening now. We talk about what it looks like now, but we don't do enough probably about what this will look like in the future. I think we're doing that more and more as we develop modeling capacities, but doing that a lot will be telling. And at the Bill and Melinda Gates Foundation, that's one of the things that drives the decision making. When we look at what's happening now and we do forecasts, we know that it's scenario planning, but it's what holds us to be afraid of what's happening today if we don't put money into parts of later. But specifically to the question that you asked me about what the numbers that we see today mean, one of the things that it means is we need to find a way, especially for Africa, to improve adoption times for innovations. That's the only way that we keep R&D alive. Because if we do R&D and it turns out that the products we're churning out will take another 20 years before they are developed, we will never get ahead of the health challenges that we need. So apart from investing in the R&D itself, we're also trying to figure out how to streamline the adoption systems in Africa. So the setting up of the Africa Medicines Agency, we hope, would then encourage the innovators to churn out more products because it will be easier to get the products out in the rest of Africa. Investments in supply chain systems and in the other national regulatory bodies are also an important investment that we should be making. But I also wanted to say that one of the other things that we want to impress on countries as they look at the numbers is as they participate in resource mobilization for some of their more pressing needs, like needs around HIV, TB, and malaria, involving them in this early involvement and constant involvement in R&D is important because, you know, if you look at, for instance, how the Global Fund raises resources, they will also carry the voices of the developing countries to their replenishment. And they speak a lot about what this money has meant, but we don't hear the voices a lot on what R&D means to them. And I feel that that's really something that we need to carry along. But all in all, when we do the research, it's giving us an indication of how much it will cost and what's the impact of health per dollar that we spend. This is really useful in also mobilizing attention to adoption for the countries.
And so, Cynthia, I mean, how can stakeholders collaborate more effectively to make sure that the bridge between innovations and adoption and access in the country level is actually improved? I mean, you spoke about development of the AMA. You spoke about supply chain considerations. Are there more things that, from a funder perspective, you'd like to see and stimulate? Because we're also talking about a wider range and more diverse group of funders getting on board. So what are the things that you would like to see in terms of how organizations collaborate in a more effective way?
You know, let me give an example. In Nigeria right now, we have a program that the foundation is supporting that's going to scale, which is about how countries use azithromycin for children between the ages of 1 and 5. It's a great program, and we have the data that says this will save children's lives, giving them a dose, 2 doses a year. But what we've done on the back of that is build the capacity of the Nigeria Institute for Medical Research to be responsible for monitoring the antimicrobial resistance that will come out of this kind of work. And what we want is for them to do this research at global standard level, rather than in the past, we really have external researchers do this work. We've even gone and been more brave and not coupled them with another agency, which we've done in other countries. But in Nigeria, we have this big ambition that we want Nigeria to own the data because they can be ahead of the conversation. Alongside that, we're also looking forward to them churning out better numbers about child mortality, doing better quality research on that. So I think we also need to just increase the participation of local institutions, but also improve the standard of what they are churning out so that it stands the test. That way, I think coupling that with the conversation where Nigeria is now interested in being a local manufacturer of azithromycin, can participate with other investors who are willing to go into Nigeria and begin to produce azithromycin. is really interesting, even beyond the saving lives of the children.
Great. So Andrea, I mean, MNV just celebrated their anniversary, so maybe tell us a bit about that in your remarks. But you know, a lot of part of the report that's come out today attributes a lot of that impact back to the malaria space itself, right? So what are some of the elements in the malaria landscape that made that difference in driving that level of impact, and how can we sustain those elements in a bit of a longer term so that you see more investment in R&D and access?
Thank you. First of all, hi, Jay.
Hi.
Nice to see you. Yes, MNV is celebrating its 25th anniversary this year. And in doing that, we are also launching our new strategy, which relates specifically to what you're saying. Let me just get at the first part of your of where is the impact coming from malaria. That we're 25 years old and that there's an impact from malaria is no coincidence. Much of this work takes time. R&D takes time. Partnerships take time. They take resources, but you cannot speed up a certain set of activities. If you need to do 3 years of clinical research, you need to do 3 years of clinical research. So there's a certain part of what has been in this ecosystem for malaria, which is about our capacity to bring partnerships, resources, and time to the project. Now, time is not infinite. And Luis was saying we need to really be talking about urgency as well. And so a major part of where we think this impact has come from is related in the report, where we begin talking about how the target product profiles of malaria have been really well aligned globally. And this is not just about where malaria drug research has come. It's about where is the vaccine, where are the insecticides, where is the work that we're doing, and how are we making sure that those are layering, that those pieces of activity are layered one against another. When we look at, for example, what we just saw in the beautiful graphics, I did feel like I was in kind of a data disco. I like that, where we see the impact of vaccines. Those impacts are absolutely layered on the impact that has been happening in what happens with nets, insecticides, and drugs, right? Those impacts are not done by themselves. And so a major portion of what we have to think about when we're thinking vertically is how are we looking across all of the interventions that are happening in a sector over time. So I think that's something that's important. I would also really like to go back to what Cynthia just said around the impact of having country-owned research and country-owned manufacturing. MNV has been working with Nigeria and Kenya and with the private sector there to be looking at how do we speed up their ability to have WHO pre-qualified anti-malarials. This number that just came from the report of the $262 billion of benefits on R&D, where the R&D is done, right? When I go and speak at a U.S. Senator's office, I speak about not just what are the lives saved, but I speak about what are the benefits to U.S. research. The way that we speed these things up and the way that we make sure that this works better is to be sure that Nigeria owns its data, and that when we're working on this, that Kenya owns its manufacturing. So I think this is the type of thing that will help us speed up moving forward.
And how can you use this data to also leverage investments? This is a year of replenishments for many organizations. And you're dealing with a lot of interventions that are heavily supported by donors, and donors are quite stretched at the moment with many different priorities. And so, on one hand, you can look at the numbers. The numbers are quite clear, but how do you use it as a leverage to make sure that there is a continued investment from donors itself on global health R&D and access? How do you use that better?
So there's a huge pressure on donors at this point, and a huge pressure, as Luis was saying, on the ODA side of things. So this allows us to speak to our friends and them to be able to speak to their parliaments about what does this mean for their own foreign policy needs. Each of the ODA investors is doing this because of their own foreign policy. Where this kind of data becomes especially interesting is when we start looking outside of traditional investment in R&D in these areas. For example, with the development banks, when we start saying, what's going to be the impact of making these kinds of investments in Nigeria and with the finance ministers and others? These are different types of numbers that help with us being able to say, this makes a difference to an economy, and therefore this real difference. These are difficult numbers to come to, and I really applaud PolicyCures for even wading in to this challenging space. Finally, I would say the other place is again with the private sector, and not just the pharmaceutical private sector. Frequently, that's where we've looked, but as we start, I was just listening earlier today to health ministers in both Nigeria and Kenya, talking about their own investment, their own support, and their own policy changes in their own countries to be looking at where are they going to be doing manufacturing, where are they going to be looking. That's not traditional donors, right? But that takes pressure off the system to start saying, how are you going to make sure that there's investment in other places that will allow for this R&D to continue and allow for the infrastructure inside of countries to grow with the R&D needs.
So, Louise, I think one of the key things we're starting to see now is also fatigue at the industry level, and I'm going to come to the other speakers on that, right? So, in order for you to do your work and to make the level of impact for the next few years, you need industry to engage, not only the innovative pharma companies, as was earlier illustrated, but also the role of local and regional manufacturers itself. Can you tell me a little bit about some of the approaches that you're taking to engage industry in a stronger way? And I'd like to hear a little bit from industry itself on, how do you make sure that these kind of numbers on the impact is really bringing back an industry that is not investing enough in access? Maybe Louise, start and kick off a conversation, and then I'll go to Thomas in a second.
Yeah. Just before I respond, and I will respond, no worries, I really wanted to, to plot or to underline what Cynthia was saying about the importance to think about how much it costs if we do nothing, and to think about the future, because the numbers we have seen here, they are extremely powerful in the way you are showing corps going to 2040. Honestly, when we look all the PDPs, what we have in the pipeline as drugs coming, the level, of return of investment we're going to have in the years to come will be amazing. So for everybody, the traditional donors, the regional donors, the national donors, everybody has to see how much it costs if we don't do this, and how much it's coming that we could really, have as return of investment. So I think this is really something very, very important to underline. Sorry for starting with that. On your second point, yes, there is something. We're seeing is that first of all, infectious disease is not always, to make it simple, the most trendy aspect in the pharma sector today. We see also that a lot of activities the pharma sector was doing in the past, today sometimes are externalized to other actors. So when in the past we used to collaborate with pharma companies with in-kind contributions, etc., now this is changing a little bit, because it's not the traditional world we had 20, 30 years ago, and we need to get adapt, I would say, with the more traditional pharma sector. There is, as you said, an evolution. We used to talk about the generic companies, but honestly, most of those generic companies, they are also thinking where they are going to do profits, and there is no such a big difference sometimes with the traditional pharma sector. So let's be careful about that. And as you mentioned, what we're also looking is the place that more national or regional initiatives will take here. We have very good examples as Brazil, for instance, where the public manufacturing and even more than that, pharma sector is today addressing a lot of public health issues in Brazil. But what it's really interesting in this example is that they didn't only focus on the manufacturing side, they developed an ecosystem with the importance of research and development. And this is something we really insist, and I think PDPs are playing an important role on that. All these initiatives Africa we're seeing will not succeed if we're not able to bring the R&D component and strengthen national R&D capacities to have a full ecosystem to succeed this way. So more or less, this is the way we're working on.
Almost going to Thomas, but Andrea, would you like to add on? Are you starting to see a similar trend that that you're struggling to get, to keep industry engaged, but at the same time you need to get more of that regional industry also to play their role?
Yes, I would say that that our pharma colleagues are under tremendous pressure within their organizations. Thomas is just saying, he's a cost center, right? So this is something that our pharma colleagues have to take very seriously, and we also simultaneously see a real growth of expertise around the world in terms of saying, yes, we're interested in the non. What would formerly have been called the generics. This is a real challenge. It's a challenge for them. It's a challenge for us. And as you say, we are continuing then also to think about where does this get expanded, and it does come back to how does the money flow in some ways as well. Part of what is really required for groups groups that are working, who really need to make sure the products get out there and that they get volume and margin, is that you need to make sure that the products are really going to get out there. We haven't really gone into that area, but how fast can a product get to market so that they can actually make a margin is one of the big challenges our pharma, our industrial partners have.
Yeah, great. And thanks for that. Thomas, I don't want to put you on a spot, but I am putting you on spots, right? I mean, you're the brave industry that's sitting on this panel. So how can we overcome that industry fatigue in investing in neglected disease and infectious disease R&D when we know for a fact that many companies have actually retreated, right? I'm not asking you to make a guarantee about GSK. Somebody else can go ask you that question, but how can you overcome that fatigue itself to stay on board? Are these numbers that have been presented here enough of a case? Or is there more that you expect from the group that's here? Tough questions.
That's difficult, but I mean, first of all, many of the things I have illustrated, we are not doing alone. We are constantly working with partners like the organization sitting to my right or to my left. We work with NIH and a lot of other not industries, but other partners are involved. What I can only say to other companies, any company is part of the society, so we have a social responsibility, and the cost center GSK is giving to us every year is substantial, but it is a small amount of the profit the company makes. So that's one thing. Sometimes I also have to make arguments inside the company for example, to say because we are producing at scale, the overall cost of goods are going down, which will indirectly benefit the commercial products as well. Another argument is here and there, we are making innovations in global health, which are then taken over by the commercial part of the organization. I mean, I'm not talking about it often, but the first clinical trials or the first product where an adjuvant was used was actually the malaria product, AS01. The adjuvant was used in the malaria development, and without an adjuvant, we could have not developed a vaccine against the parasite. But now it's in shingles, the shingles vaccine and in the RSV vaccine, which has huge advantages for the company. maybe another thing to say is, if you are not in a company, you can't imagine how proud employees are what we do in global health. So whenever I see, say, PEEP on the Facebook equivalent within GSK, everyone is incredibly proud and wants to work for a company which does these things. And I also see that the investor are looking more and more, so what are the companies doing otherwise? I mean, it's not a major driver of investing in a company, but if you have companies at par and one company shows greater social responsibility, in consumers, it's the same thing. I don't know about people in the audience, but for me, it makes a difference where I buy clothes or where I get food from, and this in a smaller way also applies to pharma companies. So I maybe drifted a little bit away, but I tried to give you different facets of the whole picture.
No, that's helpful. And in our work in Access Medicine Foundation, we actually host the largest signatory based in healthcare of investment firms that invest in the pharma industry. And more they're looking to understand which companies are actually stepping up and taking those risks in collaboration in order to expand access to products where there is a potential market failure. So it's not completely lost on the investment community at the moment, but it's obviously a very slow development in that space itself. I'm about to go to audience questions, so please get your questions ready. Cynthia, how can you incentivize more of this stronger collaboration so that you can bring back industry to cater for some of the needs that you're seeing at the country level onto this? I mean, we've heard about donor fatigue, we've heard about industry fatigue. I'm sure the PDPs on the panel are also heavily fatigued by just going through this work. No, not at all. No, they're energized by the numbers itself. So how can we incentivize this stronger in that sense? A couple of words here.
So I think one is the cost of R&D in terms of how much you have to try and fail before you get there. And those are also important conversations to be had. Maybe not so much publicizing them, but depends on which decision makers you want to be talking to. And that may be only one of many factors that may be involved in the fatigue discussion. But here's what I want to say. I think at the level of the foundation, what we have, we think a lot about this and try to find ways in which we have better partnerships. And one of the live partnerships that is very interesting is the CEO roundtable that we have that is actually chaired by Bill Gates himself and the CEOs of most of the pharma companies. And this roundtable annually is about conversations on how we can leverage each other's strength. Philanthropic money is good money to use for risky we use it to de-risk and fund where other funders may not be able to because of their mandate. As a result of the CEO roundtable discussion, I'll just give an example of one of the things that has come out of it. We had one roundtable in Kenya last year, and we agreed as a collective to work on how we penetrate the Kenyan market with AI-enabled ultrasound handheld machines. So what we are trying to do is also figure out how to keep the industry interested. And market penetration is one of those things that's just important to talk about. While we, sitting at the table, are looking at how we drive the cost of those innovations low as possible to make them affordable at a large scale, we also have to afford the private sector partners what they need in order to at a decent level recoup some of the costs. So it's a very complicated conversation, but I think having partnerships that we can all bring something to the table that doesn't take away from the objective of the other partners is good, and still maintain decent public health programs.
Right. Great, thanks for that. Let's take some audience questions, and please introduce yourself and try to keep your questions as a question. And if you want to direct it to any particular speaker, Yeah, that happens. Please, if you're trying to direct it to any particular speaker, just say so. Lady in the front. The light's bit.
Hi, Sam Rick with AVAC. I've spent many, many years telling governments about the return on investment for global health R&D, and it has fallen on flat ears. I'm wondering if you guys have any advice for advocates trying to bump up public investment in global health R&D and what we can do other than restate these, to us, magnificent numbers.
Who would like to take that? Luis? Yeah.
Very good question. I think I would like to take the example of the pandemic treaty. The work at the NDI we have been doing since the beginning of this process is to show how during the COVID pandemic, so many public funds were invested in research and development with very few return of public investment than for the people. And we are having more and more countries being aware about that because it's money that come from their citizens. This is tax, from citizens. And at the beginning, people were a little bit reluctant. What is this? We don't want to put, conditions, terms and conditions in this type of negotiation. And unfortunately, you know that negotiations are still going on this morning and we're not already there. But when we look at last year, when we started, where we were and what was the consciousness of the nations, even in Europe or in the US, we have done a lot, I would say, to convince that if you're spending the money of your citizens, the minimum is that you negotiate terms of condition on what are you going to do with the result of the research and development. So a good example there.
Great. And you can see that there's more and more embedding of access considerations within funding that's coming forward. So a couple of days ago, NIH also announced a call for what does access look like, so that they can embed that in a few of their contracts, which can be quite revolutionary if they do it right in that sense. Another question, the lady here, and then the gentleman at the back. Please introduce yourself.
Thank you. Jutta Reinhardt-Rob from Merck. I feel passionate about the cost center. Yes, I'm suffering from the same in our company, but I think we need to change the narrative. I think it's an investment case, and not only for the private sector, these numbers are great in the report, but I think we need to talk about the ministers of finance in the countries to tell them if you do not invest in this, you will not have any impact and you will not have any gains on the long term. So I think we need to be also considering, who is the audience who should look into these numbers. Thank you.
Great, thanks for that. Gentleman in the back, and then gentleman in the middle here.
Thanks. I'm Daniel Bausch from FIND here in Geneva. Very interesting talk, but I feel like I'm getting mixed messages. And so I have a very simple question, actually, and that is, why is this so darn hard? I guess, we saw those numbers and it looked very favorable in terms of return on investment. And then most of the conversation is how do we convince people to invest? And, if this was a conversation with a personal investor and someone told me you invest $1 and you get 405 back, it wouldn't be so that's kind of why, what's sort of going on in your views. And I know that's an oversimplification, but just wondered your views.
Sure. Why is it so darn hard? Cynthia, would you like to take that from your point of view? And then maybe the industry, Thomas can take that.
One of the reasons why it's hard is trade-offs. If you think about the pressure within the health sector, just to give good health to people, and if you're thinking about it, for instance, from the perspective of African countries, they have to make choices. The Gates Foundation for many years has done what needs to be done to get things right. But as most of you have heard, I hope you have heard this, we're getting to a ceiling where we will be spending $9 billion a year. And we've never had a ceiling before. We've never had to discuss a ceiling. But it means that in the future, even the Gates Foundation will be making trade-offs. And as global money almost comes to a flattening curve for public health programs, there will be more and more trade-offs that organizations need to make. So for me, the biggest issue and why this is hard is about trade-offs.
Great. Anyone else in the panel would like to add?
I mean, I'm not attacking, but I think it's an oversimplification because what these numbers show is investing in global health vaccines and medicines makes a lot of sense from a society point of view, but this money doesn't go back in pockets of pharmaceutical companies. Let's take COVID out for a second. So I think the reason I used the cost center example, I just wanted to flag, I'm not asking GSK to make money. That is the only point I wanted to make. But I mean, the numbers are great. For society, it's great. I think it is an incentive for governments to spend money because it will indirectly come back to the society across many countries.
Yep, great. Take a question here.
Thank you. I'm Francis Tongan from the Africa Public Health Foundation. I'm a member of the Governing Council. Wonderful. Congratulations. I think it's a great job. There is one reiteration in this presentation, is that the investing in health pays. I don't think that in future we'll have many voices still doubting about this kind of message, because I've been told in different countries that paying for health is increasing the expenses. So we have to put a ceiling on what we spend in healthcare. So, but this demonstration is powerful in showing that investing in health pays. It's the direction to take. Good numbers, good work, but how does it translate into the countries? The issues was raised before by the people who spoke before. The challenge before us now is how to take it down to the country level to make the government understand that what is being done in paying for health will bring return to their own people. The way the presentation was put here would not be that appealing to the Minister of Finance at the country level. Because he doesn't read that you are earning $400 by investing $1. So globally, what happens at the country level? My suggestion is to take another step. It is to take 4 or 5 case studies, countries in the different regions of the world, and do this kind of exercise of what happens in the countries where the spending in health has stopped or has even decreased, and to show the consequences vis-a-vis countries where the spending in health has increased and to see the results. And there is one important player missing in these discussions, the International Monetary Fund. Because many countries, they don't manage to succeed in increasing the spending in health, not only because the policies are not good, but because there are conditions they have to abide to. And one of them, you have a ceiling in terms of the recurrent costs you have to get in your government. Today, there are in several countries, including mine, where you get qualified people, specialists, who are sitting there and not working because they cannot be hired. You still have that that's occurring. So this is the kind of exercise that needs to be done at the country level in order to demonstrate to the ministers of finance the consequences of not spending, and hopefully to get the IMF on board. The next panel, I would suggest to policy cues to get top officials from the International Monetary Fund to sit here and provide their perspective vis-a-vis the consequences that are happening at the country level. Why we're getting the situation of a status quo. I think we have been working for many decades, but the situation doesn't change. Why? Yep. Because you are kept at the same level. When you wanted to take a step up, you are stopped. Don't spend more. I think the COVID pandemic taught us a lesson, and it taught us that the initiative is there. If I take what Africa CDC did in Africa, what the African scientists did, they went beyond all the conditions, all the blockages which were happening, and they did it, including the sequences that produced important results on how the pandemic was managed by African scientists. And they stepped into taking the steps, the procedures to manufacture. Cynthia said it very well. The importance of the local manufacturing and to value the local scientists as well. If Agnes had been here, I think that's the point she would be pounding at.
Yeah.
Should be talking about this research done in Africa to address the African problems. That would have been her message. So wonderful. I think you did a great job, Polysecure's, in bringing these elements so clearly, but you still have another step, another journey. Take it down country by country and show it how it reflects at the country level. And globally, bring in the International Monetary Fund. There's still a barrier in terms of making progress in health. And those who are dealing with the politicians, it was said by one of the members of the panel, this presentation has to go to the European Parliament, has to go to the different parliaments at different countries in Europe, in the US, in Canada, and show them that by putting money into global health is not a charity. It's a gesture of solidarity. This result, the return of $400 for $1 invested, is solidarity and could be more if instead of $1 would have been $2 or $5. So this is the message to go to the different parliaments regionally and at the country level. Because you go to the Global Fund, you go to Gavi, they are scared to mobilize additional resources because they struggle to get the members of the parliament for the different constituency to do more, to put more money, because they have to explain the results to their constituencies, what our money did. So take this presentation to them. I think you'll convince.
Yeah. So thanks for that. And obviously Polysecure and all the members of the panel and the audience now have also some work to do in using the results that are presented today to leverage the kind of change that our colleagues here were speaking about. Any comments on that? Andrea, would you like to go first?
Yeah, allow me to channel Agnes if I can. She's up there. It's right above me. So you change our photographs. So one of the things that in MMV's creating its new strategy, which we really have focused on the question about diversity, equity, and inclusion in our work, is to exactly to the speaker's point. Now, I'm not going to go into the IMF side of things; it's well beyond my understanding. But certainly, from our perspective, and taking a look at what does it mean to begin diversifying our research base? What does it mean? Not MMV's research base. What does it mean when DNDi and FIND and all of our other sister organizations do this? What does it mean when we start saying we're not just going to give lip service to manufacturing, but we're gonna really make sure that with very little incremental money, assist organizations, assist private companies in countries to start manufacturing the commodities that are needed in the country, which for some period of time may cost more money, but over the longer time will appeal to in its industrial policy. It's not health policy, right? If you're talking about how Switzerland thinks about its manufacturing, its pharmaceutical industry, not just as health policy, it really thinks of it as industrial policy. One of the responsibilities that we have in the health sector is to do two of the responsibilities that fall into the same category. One is that we need to become more efficient ourselves. And the efficiencies relate to how are we going to work together on making sure that our products are developed not only by malaria categories, NTDs, maternal health, and so forth, but how are we making sure that we're working to be more efficient so that we're not asking for, please, can we have more money for maternal health, but please, can we figure out how we're going to make create efficiencies there? And then the second thing is for us to recognize that our work has major implications in other sectors. So today at an AMR conversation and with talking to the US CDC, the issues we have right now in avian flu globally, this is an agriculture sector issue. We can't ask for more money for agriculture and more money for health. Our job is going to be to make sure that we can work within the health sector together and across the health sector so that we are absolutely saying investment in local research, investment in making sure that the researchers are providing the malaria research is investment in the countries for continuity and sustainability. And that's our job at this point, to make sure that we're taking advantage of the tremendous research capabilities that have grown around the world in the last.
So leveraging it to a wider.
Leveraging it to a much greater degree, and recognizing that this is research policy, it's industrial policy, it's science policy.
Yep, Luis, go ahead.
Yeah, maybe I would like we don't end this conversation without speaking about probably the most important topic here, that are the patients, the communities. When you talk about, for instance, governments, etc., of course, I cannot agree more. But if we talk here about neglected tropical diseases 20 years ago, more and more we're talking about neglected populations, vulnerable populations. And if I take the example of South America, okay, they are sometimes neglected from the classical R&D model, but they are also neglected by the government. I mean, I come from Chile, South America, and there are regions where there is still Chagas. And Chile is not a poor country. But if there are still populations infected by Chagas in Chile, it's because they don't interest, you know, not only an R&D model, etc., we have been discussing, but also the Chilean government. And we need to think about that, how we bring those communities, those vulnerable population, in the core of the decision around the table. And we think that's very important. And we were discussing with Polysecure, I think you are very much aware about all the work you have in front of you, and we are happy to continue contributing with you on that. And we discussed about, for instance, the gender aspect. We need to develop a gender responsive R&D, and we need to think about the impact of investing there. We need to think about children. Children are a neglected population, more than others here, more vulnerable than others, and we need to assess what does it mean, the impact of working with them. So I think definitely we have a lot to do on this, but let's always think about those patients, about those populations, and everything we're doing here and all the decisions we're doing are for them.
Thanks for that. Say a couple more questions. One more there and one more there. Oh God, no, there's quite a few.
I've got a mic already.
Short questions, please, and then we can take quite a few. I'm going to take a few questions, so be ready. Let's go ahead.
Hi, Brooke Nichols from Find. The presentation was amazing, the panel fantastic. I'm trying to put all these pieces together. And so what I'm hearing, impact enormous. Who's putting the money in and who's benefiting, I think is really an important point that's coming out. And also the understanding that global health R&D funding might be stagnating, and we might have ceilings that we didn't have before, as Cynthia was saying. And so what are the other pathways? What are the other funding opportunities that we can unlock? And sort of to the industry partners here, hearing about how the investments that were made in the global health space, how that might have affected sort of the bottom line of GSK more broadly, and actually would quantify benefits to the bottom line be helpful from motivating for more resources internally, and would that be helpful for other industry partners if we're thinking about creative ways to sort of mobilize more resources in this space? Thank you.
Yeah. Say a couple more questions. One more here.
Hi.
Oh, yeah, go for it.
Sarah Shano, Science Division at WHO. I had a question about, we're talking about R&D, and all of these numbers are about the return on investment to society, and most of that will come from R&D within the country. But what is going to enable every country to have a healthy R&D ecosystem? Does it need to be every country? Can it be regional? An R&D ecosystem requires a huge amount of effort and input. It requires training systems. It requires labs or resources to come in. So what do we need? What should we be looking for? What kind of model can you see for the future for R&D?
Yep, great. Let's take these two really quickly. Can someone take the question on how can we leverage the investment case in a stronger way from the industry, and someone on the second question on R&D? Would like to take that? Just very quickly.
Yeah, so I mean, upper management of GSK currently believes that we are on the forefront of what we are doing. Making now the point which I explained to you, and GSK upper management is absolutely aware that the evolution with adjuvant started in a global health product. That's why they are still investing. So I think I cannot get more out of it at this moment. For R&D, I have another answer. I think you don't need R&D in each and every country, but you have to make sure, and I'm looking to Africa, that questions which are relevant for Africa are addressed in Africa, because what we do in Tres Cantos or Siena might very well benefit, but we might miss things, and we have to make sure that R&D questions are addressed from different populations and worked on in the countries.
Great, thanks for that. I'm gonna take the next question first. Last question, yes.
Thanks, Philippa Easterbrook from the HIV Hepatitis STI Department at WHO. I have a quick question. A common goal in global health is to have quality assured products, and WHO has a process, so pre-qualification, and it works well for the big three, the HIV, TB, and malaria, because of the investment of Global Fund. But I'm seeing increasing retreating of companies being persuaded or trying to persuade them to submit for pre-qualification. And they simply respond that there's not a compelling business case when the funding of testing is with national governments and domestic funding. So I really just wanted to ask members of the panel to comment on how we can expand the quality assurance process to other organizations, obviously ZMA, FDA, and how we can persuade the companies, if there's not a business case, how to make the business case.
Yeah, maybe a very quick comment. Thomas, you want to take that? It looks like you want to take that.
So I'm very critical as GSK to the pre-qualification process, and I think if companies are turning away, you have to think to make a more compelling proposition. I mean, being faster, not repeating what other regulatory agencies have already covered. I think then the process is definitely needed, and there are things you do on top of what other regulatory agencies to do, but it's lengthy and repetitive. So I think the process needs revamping, and then organizations will buy in.
Great, thanks for that. So I'm going to close off the panel, and please use the timer so the reception to ask more questions to both the panelists and to yourselves and to each other. But one quick remark from each one of you. So Cynthia, maybe start off. If you think of one key opportunity for collaboration to deliver the highest impact, so we keep seeing these numbers going higher in the next few years, what would that be? One sentence. Yeah, I know. One sentence is hard. Sorry. You can make it a long.
I think looking at, I think taking advantage of where the narrative is going globally would help. Because I was listening to the question about how we can mobilize more resources in this space, or finance, or what is the model for the ecosystem. And I'm thinking that the narrative right now is not about more resources, because everybody knows that we won't have more money, but it's what's the current conversation about the use of resources that we need to take more advantage of and be making more cases about why some of that money needs to be repurposed towards R&D. So for me, it's about what's the current narrative? The current narrative is about local institutions, it's about local manufacturing, it's about trade-offs. And we need in the R&D space to think and hear those sound bites and figure out how we then get a portion of that to go into R&D.
Great. Andrea? One sentence.
You know, there are whole novels that are written in one sentence, but I won't go there. Okay. The greatest opportunity for collaboration is with the country ownership of the work that's already thus far. Means that we can continue to capitalize. The question about what should happen with WHO when Ghana is actually coming up with a strong regulatory system. Let's capitalize on what's there.
Right. Great. Thomas?
Have the end game in mind, so end-to-end planning from the beginning rather than salami slicing. That's for me the biggest impact.
Great. Luis?
The partnership, I mean, we have shown, I think, with the results that the type of partnerships our organizations have put in place work. And you have shown that doing more partnership, investing in those partnerships will bring not only financial return of investment, but also social return of investment. So let's continue doing this partnership.
Great, thanks for that. So today we've covered quite a lot in the discussion and the panel. The impact and numbers are staggeringly good. There's still a lot more work to do because I think we just got homework for all of ourselves in how we can leverage this better. I think there's a very clear economic argument. There's a very clear argument in lives saved. There's a moral argument that is used internally so that organizations are investing more. But we need to make sure that we keep industry on board. We need to keep some of the donors on board. We need to diversify the set of financing availability that's made available. There needs to be local ownership, as given by example of the Nigerian example that Cynthia spoke about. And really making that difference between what is going to happen in the next 10 years is going to be based on what we do with some of the data that's around here and some of the experiences that we've been through. So thank you very much to an excellent panel. Maybe a big round of applause, and then I'll hand over to Andrew. We'll step off and yeah.
Thank you so much, Jay. Thank you to our panel. Let's give them one more round of applause. That was fantastic. The impact of Global Health R&D report is now officially live. We've launched a new website while all of you have been sitting in the room today. You can find everything at impact.policycuresresearch.org. We have some hard copies of the report with us today. I don't know if we have enough for all of the folks that have showed up, so first come, first serve. But we do have a really beautiful digital version of this report that mirrors some of the wonderful graphics and interactive way of experiencing this data that you saw with us all today. I'll offer just a few more words of thanks before I let you all out of the room. A big thanks to the folks at Jardin des Nations and at Laurier that have made this beautiful venue available to us and helped us bring these impact numbers to life. We really couldn't have done this without our partners at Anthology. I don't know if Amy Sutton is in the room. If she is, give us a wave. Amy is here all the way from Perth, Australia. If you have any questions about their amazing work or how they brought this to life, please find her at the drinks afterwards. I cannot leave today without giving my partner in crime, Vanessa Candeias, a special thanks. And Andrea very kindly thanked us in her remarks about how murky these waters are that we've waded into, and we've come out on the other side of that. And I think we can all in this room be very proud of the work that we're doing, and we look forward to what comes down the line. We clearly do have a lot of homework left to do. Please stay. We have a beautiful reception outside in the garden. I think this is the only sunny day this week, so please join us outside before we start our homework. We can take a moment to celebrate. Thank you all for coming.